Patients here.
Oh boy, got some blood going.
Yeah, this is with blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in epilepsy
in your left hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Usually when we talk about a medical diagnosis, there's this expectation of precision. It's a lot like engineering. You break your arm, the x-ray shows that jagged white line, and the doctor just points to the film and says, right there, that's the problem.
Right, yeah, it's completely binary, broken or not broken, and that's, it's a clean, visible categorization, which is incredibly comforting for both the clinician and the patient.
Exactly. But then you step into the world of psychiatric pharmacology, and suddenly that x-ray machine is just broken. We're looking at a diagnostic and therapeutic landscape that is, honestly, it's completely murky.
Oh, absolutely.
You can't just point to a single fractured bone in the mind. And that is exactly why we are doing this specific deep dive today. So welcome in. Today we are giving you a shortcut. We're cutting through the noise to extract the exact clinical realities of one of the heaviest hitting medications you will encounter on the floor.
Yeah, we are applying the Pareto principle here. We're identifying that critical 20% of clinical information that is going to give you 80% of your practical understanding.
Right.
Whether you're taking your nursing boards or you're managing complex patients in an acute care setting.
And the drug under the microscope today, it's a heavy hitter, like I said, Zyprexa.
Generically known as Olanzapine, though Zyprexa is the brand name you'll most often see. Clinically, it belongs to the class of antidepressant augmentation agents, and more specifically, it's a multi-acting receptor-targeted antipsychotic.
Which is a mouthful.
It is, yeah. We usually abbreviate that to MARTA, but broadly speaking, in daily practice, most people just refer to it as an atypical antipsychotic.
Okay, let's unpack this. I really want to look under the hood and figure out the mechanism of action. So to understand how olanzapine actually works, I want you to imagine the human brain as a massive, incredibly complex soundboard in a recording studio.
I like that analogy.
Right. So in a condition like schizophrenia, the dopamine dial in a specific area of the brain, the mesolimbic tract, is turned up way too loud. That excess noise causes the positive symptoms, the hallucinations, the delusions, the things that are, added to the patient's reality. But simultaneously, in another area called the mesocortical tract, the dopamine dial is too quiet. And that causes the negative symptoms, like a completely flat affect, a lack of motivation, or severe social withdrawal.
Yeah, and older typical antipsychotics used to just aggressively turn down the dopamine dials everywhere across the entire soundboard. And sure, that stopped the hallucinations, but it led to a host of other debilitating problems because dopamine was suddenly depleted in areas where it was desperately needed.
Right, the side effects were brutal.
Exactly. But olanzapine modulates this soundboard far more elegantly. It blocks dopamine receptors, specifically the D1 through D4 receptors, but it pairs that with the blockade of serotonin receptors, specifically 5-HT2A and 5-HT2C.
So it's that specific combination of dopamine and serotonin antagonism that actually reduces both the positive and the negative symptoms of schizophrenia.
Exactly. By blocking those specific serotonin receptors, it actually helps modulate and optimize dopamine release in the areas where the dial was turned down too low while, keeping the loud hyperactive pathways in check.
That's fascinating.
Yeah, it's a much more balanced therapeutic effect.
Which means we get a reduction in the positive and negative symptoms of schizophrenia. We get mood stabilization in bipolar I disorder, and it can even mitigate treatment-refractory depression when it's used as an adjunct. But wait, I have to push back here for a second.
Okay, go for it.
If it is just elegantly targeting dopamine and serotonin to stabilize mood and perception, why does it make patients so incredibly tired? Like, why are they always complaining of dizziness and dry mouth?
Because you aren't just hitting dopamine and serotonin. Olanzapine has what we call a really messy receptor profile. It doesn't just neatly bind to the receptors we want and call it a day. It has a very high in vitro binding affinity for histamine H1 receptors.
Oh, like Benadryl.
Exactly like Benadryl. Think about when you take an over-the-counter antihistamine for allergies. It knocks you out. When olanzapine blocks histamine in the brain, you get profound, heavy somnolence.
Okay, so that explains the intense fatigue. What about the dizziness, though?
That comes from the fact that it also strongly antagonizes alpha-1 allergic receptors. Your alpha-1 receptors are responsible for keeping your blood vessels constricted, which maintains your blood pressure.
So it drops the blood pressure.
Right. When olanzapine blocks them, your blood vessels relax too much. So when the patient stands up, the blood vessels can't constrict fast enough to fight gravity, leading to orthostatic hypotension. The blood pressure drops, the brain doesn't get enough oxygen for a second, and they feel incredibly dizzy.
That makes perfect mechanical sense.
Yeah.
And I'm guessing there's a reason for the dry mouth, too.
Yes. On top of the histamine and alpha-1 blockade, it moderately binds to muscarinic receptors, specifically M1 through M5.
Ah, the anticholinergic effects.
Exactly. When you block muscarinic receptors, you are essentially turning off the rest and digest secretions of the parasympathetic nervous system.
The classic dry mouth stuff.
Yeah, severe dry mouth, urinary retention, constipation, and blurred vision. It's a shotgun approach in some ways. You're absolutely hitting the therapeutic targets you want, but there is significant collateral receptor blockade happening at the exact same time.
Wow. Okay, so if we are achieving this broad receptor blockade, calming the brain soundboard, but also causing profound sleepiness and blood pressure changes, who's the ideal candidate for this drug? Where are clinicians actually deploying this on the floor? Obviously, the common uses make sense based on what we just discussed, right? Schizophrenia, bipolar I disorder, and treatment-refractory depression.
Sure, but the priority nursing uses actually go far beyond the psychiatric ward. This is a huge clinical pearl. Olanzapine is highly effective off-label for breakthrough chemotherapy-induced nausea and vomiting.
Wait, really?
Yeah, often referred to as CINV. It is also used off-label for severe delirium in the pediatric intensive care unit.
Wait, hold on. Why are we giving a heavy-duty, atypical antipsychotic to a young child with cancer just to manage their nausea? That sounds, I don't know, so extreme.
It does sound extreme until you look at the underlying pharmacology. Remember that messy, broad receptor antagonism we just talked about?
Right, the shotgun approach?
Exactly. When a patient is undergoing aggressive chemotherapy, multiple different neurotransmitter pathways in the brain are triggered, all signaling the body to vomit. When you combine olanzapine with a corticosteroid like dexamethasone and a standard 5-HT3 antagonist, you are essentially building a wall.
Oh, wow.
Yeah, that massive receptor blockade provides a powerful multimodal block against the brain's emesis pathway.
So you're basically shutting down every possible avenue the brain has to trigger nausea.
Precisely. Clinical trials in children as young as 3 showed it significantly improved vomiting and nausea control compared to standard regimens. It's about utilizing the drug's collateral effects as a primary therapy.
That is brilliant. What about the pediatric ICU delirium?
For that, they're using very small doses, sometimes starting at just over 0.5 milligram to calm the severe, dangerous agitation that happens when a child's brain is completely overwhelmed by critical illness.
That is wild, but it completely tracks with the pharmacology. Let's shift gears and trace the drug's journey through the body, the pharmacokinetics, because how the body processes olanzapine seems just as complex as how it acts on the brain.
Oh, it is. It's heavily dependent on the route of administration. If a patient takes olanzapine orally, it's well absorbed, heavily metabolized by the liver, and peaks at about 6 hours. It has an elimination half-life averaging 30 hours, so it sticks around for a little over a day. But the extended-release intramuscular injection, known as Zyprexa Relprev, is a completely different beast. Slow dissolution from the injection site means it has an effective half-life of 30 days.
Wait, 30 days?
30 days.
If a patient has an adverse reaction on day 2, you can't just pump their stomach or dialyze them. The drug is already in the muscle tissue, slowly releasing for a month. How do clinicians mentally navigate that level of locked-in risk?
It requires extreme clinical vigilance, which we will definitely cover when we get to the black box warnings. But before we get there, we need to talk about how the body clears the drug.
Right. Let me ask a strategic clinical question then.
Yeah.
If I am the nurse on duty and I have a patient with failing kidneys, say their creatinine clearance is tanking and they are bordering on renal failure, do I need to panic about their olanzapine dose building up to toxic levels?
No, and that is a crucial point for clinical practice. No dosage adjustments are required for renal impairment.
None at all.
None. Even though about 57% of the drug's metabolites are eventually excreted in the urine, it is hepatic metabolism, the liver, that is the main driver of its clearance. And importantly for our critical care folks, Olanzapine is highly protein-bound and has a large volume of distribution.
Meaning it's not removed by hemodialysis.
Exactly. Hemodialysis won't touch it.
Okay, so the liver is the star of the show here, specifically the CYP1A2 enzyme. And here's where it gets really interesting when we look at drug interactions. What is one of the most common habits you see in psychiatric populations? Smoking.
Yes, absolutely.
Because smoking tobacco actually induces the CYP1A2 enzyme. It throws the liver into overdrive, which drastically accelerates the metabolism of the drug.
Right.
So imagine this scenario, right? A patient is admitted to a strict, smoke-free inpatient psychiatric facility. Over a couple of weeks, they get perfectly stabilized on a specific dose of olanzapine. Then they get discharged. They walk out the front doors, immediately light up a cigarette in the parking lot, and go back to a pack-a-day habit.
It happens all the time.
Suddenly, their liver is chewing up the medication way faster than it was in the hospital. Their blood levels of the drug plummet, and they suffer a massive psychotic relapse, even though they are taking their pills exactly as prescribed.
That is an incredibly common real-world interaction that nurses and prescribers must anticipate. You have to monitor their clinical status closely if their smoking habits change.
Definitely. Are there other major interactions?
The other major dangerous interaction is co-administration with central nervous system depressants and alcohol.
Because of the H1 and alpha-1 blockade we talked about earlier.
Exactly. The drug is already making them profoundly sleepy and dropping their blood pressure when they stand. Adding ethanol or a benzodiazepine to the mix exponentially worsens cognitive and motor impairment.
That's a recipe for disaster.
It is. It can lead to severe CNS depression, respiratory issues, and devastating falls.
Which brings us directly into the danger zone, the side effects, and the severe adverse effects. You have to warn your patients about the common nuisance effects, which are honestly staggering. Up to 48% of patients will experience drowsiness. That's almost half.
It's massive.
A weight gain occurs in up to 31% of patients, and appetite stimulation in up to 29%.
The weight gain is severe, and it's not just a cosmetic issue, it is fundamentally metabolic. It alters how the body processes lipids and glucose. But we have to contrast those common effects with the life-threatening adverse reactions. We're talking about neuroleptic malignant syndrome, or NMS.
Let's pause and define that, because NMS is terrifying. It's essentially the brain's thermostat and muscle control centers going completely haywire in reaction to the dopamine blockade, right?
Exactly. You're looking at a sudden, dangerously high fever, extreme autonomic instability, so their blood pressure and heart rate are erratic, and what we call lead pipe rigidity in their muscles. It is a severe neurological emergency that requires immediate discontinuation of the drug and intensive care.
Then there is tardive dyskinesia,
which is a risk with any antipsychotic. Because you are blocking dopamine receptors long-term, the receptors can become hypersensitive. This leads to involuntary repetitive body movements, often lip smacking, tongue darting, or grimacing.
That doesn't just go away, does it?
That's the tragedy of tardive dyskinesia. Even if you stop the drug, the movements can sometimes be permanent.
You also see a risk of degress syndrome in the literature. Drug reaction with eosinophilia and systemic symptoms. Basically, the immune system panics and launches a massive inflammatory response.
Yeah.
It usually starts with a widespread rash and a fever, but it can rapidly escalate to multi-organ failure, particularly the liver.
And tying back into those metabolic effects we discussed, you have to watch out for sudden, extreme hyperglycemia. Patients can develop medication-induced diabetes so rapidly that their first symptom is being thrown straight into diabetic ketoacidosis.
The blood sugar spikes so high, the body starts breaking down fat for fuel at an uncontrollable rate, flooding the blood with acidic ketones. That is a massive clinical red flag. Which logically brings us to the highest stakes information in our source material, the 3 critical black box warnings.
Right. So the first black box warning is an increased mortality risk in geriatric patients with dementia-related psychosis. Atypical antipsychotics are absolutely not approved for this use, and the labeling strictly warns against it.
But we should explain why they die, right? It's not usually a mysterious toxic reaction. You have an elderly patient whose cardiovascular system is already fragile. You give them a drug that causes extreme orthostatic hypotension and sedation. They wake up in the middle of the night confused. They try to stand up, their blood pressure drops, they fall, and they break a hip.
Exactly. Or they become so sedated that they lose their gag reflex, aspirate their food, and develop fatal pneumonia. The mortality risk spikes because of the secondary consequences of the drug's pharmacology.
That makes a lot of sense.
Yeah. Heart failure, sudden death, and infectious pneumonia are the leading culprits. The second black box warning is an increased risk of suicidality in children, adolescents, and young adults when the drug is used in the context of treating major depressive disorder.
And the third warning is entirely specific to that Relprev extended-release IM formulation we discussed earlier, the one with the 30-day half-life.
It's called post-injection delirium sedation syndrome, or PDSS.
Okay, what causes that?
This happens if the drug inadvertently enters the bloodstream too quickly from the gluteal muscle rather than slowly absorbing over a month. It causes a sudden, massive spike in Olanzapine plasma concentrations. The patient will exhibit severe sedation, profound delirium, ataxia, and it can rapidly progress to a coma.
So based on those black box warnings, there are hard contraindications. You absolutely avoid giving this to elderly patients with dementia, Parkinson's disease, or delirium, as outlined in the Beers criteria. And if you work in a long-term care facility, the OBRA guidelines are incredibly strict. You can only use it if the patient is a documented physical danger to themselves or others, and you have to attempt gradual dose reductions continuously.
You cannot use it simply as a chemical restraint to keep a wandering dementia patient in their chair. The mortality risk is just too high to justify it.
So how do all these dangers change the physical, hands-on actions a nurse or clinician must take? Let's talk interventions and patient education.
Well, there are some very specific administration quirks. First, the orally disintegrating tablet, or ODT. There is a specific foil trick.
The foil trick.
Yeah. You have to leave the tablet sealed in the blister pack until the exact second you are ready to administer it. You must peel the foil back with completely dry hands, and you must never, ever push the tablet through the foil.
Because it's highly friable, right? If you push it, it's just going to crush into useless powder.
Exactly. But once you successfully place it on the tongue, it dissolves in the patient's saliva almost immediately.
And then there is the Relprev protocol, which, given the risk of that sudden delirium syndrome, is incredibly intense.
It must be administered via a deep gluteal intramuscular injection using a 19-gauge needle.
Why specifically 19 gauge? That's a pretty thick needle.
Because the suspension itself is very thick.
Yeah.
If you use a smaller gauge, the medication will clog the needle during administration, and you won't deliver the full dose. Furthermore, it can only be given in a registered healthcare facility that is enrolled in a specific restricted distribution program.
Oh, wow.
And because of that black box warning for PDSS, the nurse must continuously observe the patient at the facility for at least 3 full hours post-injection.
3 hours of continuous observation in a busy clinic. That is a massive drain on clinic resources and physical space, which really tells you just how dangerous and rapid that complication is.
Yeah.
And they can't just drive themselves home after the 3 hours are up.
Yo, they cannot. You have to confirm they have a chaperone physically present to take them home before you even administer the injection. If they don't have a ride, you hold the dose.
That's strict.
It is. Other independent nursing actions include conducting frequent fall risk assessments, especially when initiating therapy, and monitoring their sodium levels. Because atypical antipsychotics carry a risk of syndrome of inappropriate antidiuretic hormone, or SIADH,
where the body holds on to too much water, diluting the sodium in the blood to dangerous levels, which can eventually trigger seizures.
Precisely. You have to watch the lab work.
So when you are standing at the bedside or doing discharge teaching, what do you tell the patient? You tell them to avoid alcohol completely, for obvious reasons. You tell them not to drive or operate heavy machinery until they know exactly how the drug affects their motor skills.
Right.
And for those Relprev patients, you make sure they and their caregivers know the exact signs of PDSS, extreme sleepiness, confusion, dizziness.
You also urgently need to counsel them on the metabolic risks. They need to monitor their weight closely, and they need to report any sudden excessive thirst, frequent urination, or extreme hunger, as those are the classic early signs of medication-induced diabetes.
Okay, so what does this all mean for you on the floor, or when you sit down to take your NCLEX exams? Let's rapidly distill everything we just covered into our nursing school priority summary. Based on the Pareto principle, what is the absolute must-know?
The must-know revolves entirely around the black box warnings. You do not give Olanzapine to elderly patients with dementia due to the drastically increased mortality risk. And you must strictly observe Relprev IM patients for 3 hours post-injection for post-injection delirium sedation syndrome.
Got it. And the nice to know.
The nice to know is that it is a surprisingly powerful off-label tool in oncology for chemotherapy-induced nausea and vomiting, and in the pediatric ICU for severe delirium.
Awesome. And what is the test trap they need to watch out for?
The test trap is threefold. Do not push the orally disintegrating tablet through the foil. Remember that smoking a CYP1A2 inducer accelerates the drug's clearance, which could cause a relapse. And critically, renal failure does not require dosage adjustments.
And our clinical red flag?
The clinical red flag is watching for profound CNS depression if the patient combines the drug with alcohol, and monitoring closely for massive weight gain or the sudden onset of diabetic ketoacidosis.
Which leaves us with the one-sentence memory hook to tie it all together. What have you got?
Remember this, Olanzapine zaps psychosis and oncology nausea, but watch out for the weight gain, the elderly, and that strict 3-hour post-injection watch.
Olanzapine zaps psychosis. That is definitely going to stick in a lot of heads.
Yeah. You know, if we connect this to the bigger picture of psychiatric pharmacology, there's a really fascinating paradox here. We look at the severe metabolic effects, the massive weight gain, the hyperlipidemia, the sudden risk of diabetes.
Yeah.
And it forces us to ask a difficult clinical question. If a medication successfully saves a patient's mind, but simultaneously puts their physical metabolic health in severe jeopardy, how do we as healthcare providers effectively balance the healing of the brain with the collateral damage to the body?
That is the exact tension clinicians are navigating every single day. You're trying to fix the x-ray, but you're swimming in those murky waters. It's not just a binary choice of broken or fixed. It's a constant, careful modulation of risk and reward. And we will leave you to mull that over during your next shift or study session. Thanks for joining us on this deep dive. See you next time.